Hello, hello, hello. This is Marshall Goldsmith. So happy to be joining you today on LinkedIn Live. This is by far the most important show that we've ever done. Today, a big topic, how to win the war on COVID-19. Not how to kind of slide through this or get by, how to actually win the war. And I have just a personal hero as my guest today. And let me briefly introduce myself, and then my wonderful comrade, Sun Yun Chang, is going to introduce herself. Then we'll get to work with Dr. Yong Kim, who's just a great human being. Well, let's get rolling. First, my name is Marshall. I'm from a small town called Valley Station, Kentucky. Went to school in Indiana. Got a Ph.D. at UCLA. Was college professor and dean when I was young. Then for the past 43 years, I've done three things. I give talks or teach classes, so I travel all around the world speaking and teaching. And then I coach executives. I've been the coach of wonderful people like Dr. Jim, and Jim's met many of my other clients, and people like the CEO of Walmart and the Mayo Clinic and New York Public Library and Ford and Pfizer and Glaxo, wonderful people. And what I love about coaching people like Dr. Jim is, although in theory I'm supposed to teach these people, I actually learn far more than I teach from these wonderful people. So I'm very blessed to even know such people. Then the third thing I do is write and edit books and articles. I've written or edited 41 books, 6 bestsellers, 3 big New York Times bestsellers, and the others purchased only by my mother, my father, and associated relatives. I'm also a founder of something called 100 Coaches, which is a spectacular organization. Dr. Jim and Sun Yun, I'm proud to say, are members of this group. And the goal of this is, I came up with this idea, just teach everything I know to others for free, get them to teach each other for free. And the only price is when you get old, give back. So it's just a wonderful group of people, 100 coaches. And one of the members I'm very proud of is #1 coach in the world. I used to be #1 coach, but now I'm in what's called the Hall of Fame, where they put old people. The new #1 coach is Sun Yun Chang. Sun Yun, briefly introduce yourself. Spectacular human being.
Thank you so much, Marshall. I've learned so much from you. Hi, everyone. I'm Sun Yun Chang, and I help leaders reimagine, reinvest, and be more resilient towards a better and more positive future. I work with military generals, CEOs, tech founders, and I am the executive director at the Fuqua Coach K Center on Leadership and Ethics at Duke University, where I am also a professor at its Pratt School of Engineering.
You know, Dr. Jim, Sun Yun, we are joined today by Dr. Yong Kim. You know, Dr. Jim, just an amazing person. Dr. Jim, I've known for many, many years. He has an MD and PhD in anthropology from Harvard. He has taught there. He has also done an amazing job. He is a founder of Partners in Health, which is just an amazing organization. It's done so much good for the world. He then was president of Dartmouth College, where I had the privilege of meeting him at Dartmouth, where he was president, went on to be the head of the World Bank for many years, did a spectacular job as head of the World Bank, had a wonderful job as, vice chairman of Global Investment Partners, also doing great work. Yet this came along. And when this came along, I really think Dr. Jim felt a calling. And his calling was, we got to get to work and we got to fix this. So Dr. Jim, if you can briefly introduce yourself. First, thank you so much for joining us. I'm so honored to know you. And just introduce yourself, a little background of who you are, and we're going to get rolling.
Thanks so much, Marshall. It's great to be on with you and with Sun Yun. We really have developed a wonderful community in the 100 Coaches group, and it's building on the community that you've been putting together for many years now. It's been great that I've gotten to know so many of your other clients. And so, my background is I was trained as a physician and an anthropologist, and I was also trained in infectious disease. And so in the early part of my career, we took on major pandemics, major epidemics and pandemics. And the first major one that we took on, in which we really had to fight difficult battles, even with other public health specialists, was drug-resistant tuberculosis. At the time when we started in 1995 or so, seeing all of these patients in a slum in Peru with multi-drug resistant tuberculosis, we thought, oh my goodness, there's so many cases. These families are infecting each other. They're dying of drug resistant tuberculosis. We got to do something. And literally the entire tuberculosis public health community said, no, it's impossible to do. You can't do it. You shouldn't do it. And they were even angry at us for even suggesting that it could be done. So we showed that it could be done, and the World Health Organization eventually changed its policy. And then right after that, we saw this huge epidemic, a pandemic really, of HIV. And so many of the people who were living with HIV were living in Africa. And we started saying, we've got to treat HIV in Africa. But at that time, once again, the entire HIV and public health community said, no, it can't be done. It's impossible. It's too difficult. It's too expensive. And so we started by just showing that it could be done in Haiti. We convinced not very many people in the public health community, but then things started to change. And we eventually were able to convince the public health community that we needed to treat HIV in Africa. And, I would say things in meetings, in large meetings at the World Health Organization and elsewhere, because by then, 2003, I'd taken over as a head of HIV department at the World Health Organization. I would say things like, if we don't treat the 25 million people in Africa living with HIV/AIDS, we will forever be remembered as the generation who let a genocide happen right in front of us. And so we won that battle, and now there's some 23 million people on treatment of HIV. At the World Bank, I was watching in the summer of 2014 as the response to Ebola was just not happening. I couldn't believe that it was moving so quickly. And so I got the World Bank involved, and we were the first ones to provide any large sum of money for fighting Ebola in West Africa. So I've been at this for a long time. And one of the things I've been watching is that I think for all kinds of reasons that are some very understandable, others less understandable, the public health community is sometimes shy about really tackling these major, huge problems, and sometimes giving the sense that we have an option of deciding whether to tackle them or not. That's what I started seeing in the COVID-19 response. And so I felt like I had no choice but to get involved.
Dr. Jim, what I like about what you're doing is we're not talking about a Band-Aid here. We're not talking about some Band-Aid or cover it up or it won't be that bad. You're talking about winning a war here. And it's not going for a tie. You're talking about winning a war, which I really think you're right. I totally believe in what you're doing. And by the way, here's a criticism. What Dr. Jim is going to tell you is going to take a lot of time and effort and people and money. To me, well worth it. The reality is we are blowing trillions of dollars on the economy, and we're just getting warmed up compared to what we're going to be spending if we don't do this. Dr. Jim, how can we win this war?
Well, Marshall, one of the things that I was very lucky to experience in my life is that in 2003, a very close friend of mine whose campaign I ran for the director generalship, I was one of the leaders of his campaign to become director general of the World Health Organization, and he was elected in January of 2003. And so he asked me to lead his transition team. And so in doing so, I met all the people who were finishing up the global response to SARS. They were the ones who were giving the messages out, and they were a fantastic group of people. And the good news is Mike Ryan is now in charge of all epidemic response in the World Health Organization, and he's a very close friend of mine. Anthony Fauci, who folks in the United States know as being such a wonderful voice of science and reason in the United States. Tony was also a friend of mine because we worked on HIV together. Tony was one of the few scientists who were supporting our efforts to treat HIV in Africa and other places. And so I started calling them, and I said, what are we learning from the rest of the world? What's this? What is this virus acting like? What is it doing? And I also called folks at the Korean Centers for Disease Control and talked to them directly about what their sense of this virus. And I began to understand that this was a once in a lifetime virus. Unfortunately, it may come back every year, but this is a once in a lifetime virus. That this was, as the Koreans called it, sneaky, nasty. The folks who were actually out there fighting it every day talked about it almost as if it was a person, and that this was one of the nastiest, sneakiest, deadliest people that they'd ever run into. And so the most important lesson of all this is that you cannot stop this virus with any kind of simple or one-dimensional measure. And so social distancing, which is what we're doing now, really, really important. But in every setting in which there has been a relatively greater degree of control over the virus, they did not just do social distancing. In China, in Wuhan, what we learned is that social distancing got them only so far, but that the epidemic was still growing, or just barely stopped growing with just the social distancing. It was only after they added much more widespread testing, contact tracing, and then an effective system of isolation and quarantine. In Wuhan, China, the isolation and quarantine they implemented is probably not doable in the United States. It's too forced. But boy, in Korea, in Taiwan, in Hong Kong, in Singapore, Singapore's having more problems now. But in all of those places, including Australia and New Zealand now, they did testing, contact tracing, effective isolation and quarantine. And that's what made the rate of new infections go down instead of just flattening out. So we know that. And so I was sitting here in the United States, kind of incredulous at how quickly the public health experts in the United States gave up on that approach. They said very early on, even when there were, and Marshall, you've told me this many times, even now there are states with very few cases. And even for those states with very few cases, public health experts seem to have given up. It's too hard. It's too complicated. There are too many cases. It's too late. And the one thing we've learned is it's never too late. Get started now, because every day the job gets harder.
Dr. Jim, I love what you're saying, and I am shocked at how we do not learn from other people's experience. I mean, look, how countries, Italy, Spain, they have these problems. It's not like we didn't see it coming. And now what I'm even more shocked is the small states are not learning from New York. In the less populated states, there isn't some huge cost. They could do exactly what you're saying right now in Wyoming and in some of these other states that don't have so many cases, and they could prevent this New York style disaster from happening. So I am totally aligned with what you're saying. And I do think the small states, as well as the large states, need to step up to this. And also, I totally like your idea of, look, we got to get rid of this thing. This is not a Band-Aid. This is not a short-term solution. Now, Dr. Jim, you talked about the importance of time-tested strategies. And I love your example of cholera. Can you share that with the group?
Yeah. The most famous and maybe one of the first epidemiologists was a guy named John Snow, 150 years ago. And there was a terrible outbreak of cholera in London. And what he did was he traced all the cases. He went and interviewed all the people who had the cholera, or the family members of people who died from cholera. And he traced all of them back to a single water pump in London. And he determined that water pump was the source of cholera. And so all he did was he took the handle off the pump, and then the cholera outbreak stopped. So this is a lesson that every single public health person learns, and it's the importance of what we call shoe leather epidemiology. Actually getting out there and talking to people to figure out where they've been, where in this case where the virus is, and then what to do to stop the transmission. And so a lot of people have said to us, "Why are you doing this with people? Why don't you just do it with technology?" Well, the the importance of shoe leather epidemiology has never gone away. Now, in the Massachusetts program, and we just got started about 2 weeks ago on a program to do exactly this kind of scale up of response in Massachusetts. In Massachusetts, we're not going and knocking door to door. We're doing it by phone, which is makes it much easier in the sense that most people have phones. We couldn't do that in West Africa where most people didn't have phones, but we can do it by phone. And it turns out that not only were the people who answered the call, many of them, not only did they answer the call, but they were so happy to hear someone's voice. And so I don't think that we're ever going to be able to move away from the people contact that's necessary in fighting a virus like this. We're hoping that apps can help us. I can't tell you how many emails I've gotten from people who are very excited about their app and literally expect me to find a way to use their app in the program that we're implementing. We probably will end up doing it, but that fundamental shoe leather epidemiology that says we care about how you're doing, we care about your ability to protect yourself and your family, and we're going to keep in touch with you. We're going to help you all the way through this process. That's been one of the most important lessons we've learned in the early days of the program in Massachusetts.
Why don't we do this? I would love it if you would just take a step-by-step approach. For many of the viewers are not aware of what you're doing or how it works. And again, just take a step back and take a step-by-step approach of how might this work? What are the steps involved in the process?
Well, so the first thing would be political will. Somebody in a position of importance, a position of power, has to say. And in the case, it was Governor Baker. And a half weeks ago, I think now, that I had my first conversation with Governor Baker, and as he's told the story now several times in newspaper articles. He says that he was in his car actually when he took the call from me, and this was at a time 5.5 weeks ago when literally every single public health expert was saying it's too late for contact tracing, it's too late to go on the offensive, you can't do it. And so I had to convince Governor Baker that while everyone was saying this was impossible, that he would agree to do it. So I laid it out for him, and I think the thing that struck him was I said, you can go on offense against the virus. That's what all the countries in Asia are doing that are having success. And he said he liked that idea. He did feel that in Massachusetts that we were just sort of leaning back and waiting to see what the virus was going to do. So he agreed to it, and then we had to look at what was existing in Massachusetts. Every state has some kind of system in place, and Massachusetts has the oldest public health system in the United States, and they're extremely good. It's just that there were so many cases, they weren't able to do the contact tracing on all of them. So we had to figure out how to integrate perfectly with local boards of health, the community health centers, and we also had to figure out how to get information on the cases without violating privacy laws, right? So we had to go through all of these very specific things. But now what happened, the goal is every time a test is positive, and the good news in Massachusetts is that testing is scaling up very, very quickly. A wonderful institute called the Broad Institute is now going to be doing between 20 and 30,000 tests a day. This is a game changer for Massachusetts. And because we're doing that, we're now going to be able to test everyone we need to test and want to test. So as soon as a test turns positive, our team is notified. We call that person. We talk to that person and figure out all the people that they've been in contact with. Then we call those people. And we're now working to ensure that the people who are positive and the people who are close contacts have a way of keeping themselves safe and not infecting anyone else. In China, they took everyone out of the home because for the most part, people were living in very tiny apartments, and there just was no way for family members to isolate themselves from other family members. In Massachusetts, there are people who have nice homes and actually can isolate at home, so that's fine. But then there are many others, especially in some of the poor communities, that are living, 5 to a single room apartment. We need to find ways of protecting them. And so for every single case that's positive, we try to stop transmission between that person and their households, and then from the households outward. And we're going to keep building and keep building and keep building until we're confident that we're detecting every case, that we're stopping as much as possible any transmission from that case to anyone else. And when we get there, that's when you're going to start seeing the cases grow. When we have, the social distancing stops transmission between households very effectively. But then what's happening what happened in China, what happened in Korea, what happened in now Spain and Italy, is that the new cases are coming from household contacts. So social distancing cannot stop transmission within households, but does very well between households. If you stop both those chains of transmission, that's when you see the rates come down. So, right now, most of the U.S. is saying, well, we want to go off of lockdown, and so we're going to have testing and contact tracing in order to, chase down cases. Well, the first thing they need is to see that rate drop, and the way they do that is exactly the same: testing, contact tracing, isolation, and quarantine.
Dr. Jim, the counter argument to the approach you're talking about could be considered Sweden. In Sweden, they're basically saying we're going to quarantine old people, quarantine people with previously existing conditions, and then everybody else, we're going to go for herd immunity. Basically, if you get infected, you get infected. We want to flatten the curve to a degree so we don't flood the hospital system. Yet we're basically going for long-term herd immunity, which on the surface seemed to kind of make sense to me. Yet you and I had a very good discussion about why this won't work in the United States. And I think you've said it. In the United States, we have a lot of poor people who are disproportionately hit by this. We have minority communities who are disproportionately hit by this. And we have a lot of kids being raised by their grandparents. And, if you don't get this at the level of the kid, as you said, in the household, it's going to go to the grandparents. The grandparents are going to die. They're going to flood the health system. So can you just talk about why that approach of Sweden, which may or may not work in Sweden, I definitely don't think it's good for here. Why you don't think that approach is a good approach for here?
Well, Sweden, boy, I wish them all the best luck in taking their approach. It's not a choice I would have made, but boy, I do wish them luck. And if for some reason, if the virus behaves differently in Sweden, you may get a better outcome. But already Sweden has much higher death rates than neighboring countries, Norway, Finland, Denmark. They already have higher death rates. And, a friend of mine from the World Health Organization who took a look at what was going on in Sweden a couple of weeks ago was saying, well, it looks like the Swedes are trying to follow social distancing guidelines. It's just not necessarily in the home. Well, the latest reports I'm hearing are that, in fact, they've gotten very loose. They're having large gatherings, graduation parties and the like. And so, again, if there's something different about the virus in Sweden, if it's going to behave differently in Sweden than it's behaved elsewhere, I think that's great. And if then we see that replicated elsewhere, then that's even better. But I wouldn't say that the Swedish approach is an evidence-based approach. They're trying to go for herd immunity. I don't know. I think that the numbers that we've seen so far on what percent of people in the world are infected or not infected, the World Health Organization said that they had expected about 5% of the world to be infected, but but I think maybe 2 or 3 days ago they published a paper saying it's only 2 to 3%. So from the perspective of a public health person, only 2 to 3% means there's a lot of what you call dry kindling out there, and I can't imagine how you would do this in the United States. Would you say that all African American communities would be quarantined? I mean, in Illinois, Governor Pritzker told me that 70% of his deaths are in the African American community. Wisconsin, 6% of the population is African American, and over 40% of the deaths are in the African American community. The nastiness, the sneakiness of this virus is it seems to go down the fault lines of society. It goes after, it preys. Thankfully, it doesn't prey on the young. The flu pandemic of 1918 preyed on the young, and that was extremely tragic. But this seems to prey on people with existing conditions. It seems to prey on people living in poverty. Part of it, I think, is that that's much harder for them to socially isolate and quarantine if they do feel that they have the symptoms. It's absolutely devastating homeless shelters, devastating the nursing homes, and so I don't think it's possible to have a strategy that says that all of those groups have to not participate in the economy for a long period of time, and then let everyone else get herd immunity. When would those groups then re-participate in society? And the way I look at it is, are you going to do this every single time a virus comes? Are you going to let all of these people die? I mean, we're talking about like a mass culling. This is not herd immunity; it's herd culling. And I don't think that morally or ethically we can embrace that. What instead we should embrace is a very difficult, very large, very complicated project that has been proven to be effective in other parts of the world. And right now, the only argument that I'm hearing against it is that it's too hard, it's too complicated, it's too expensive. Well, you said it, Marshall. 2.5 trillion so far, and it looks like
Right.
because the curves are just flattening, they're not going down. How many more times are we going to have to do that? And so I keep saying to anyone who will listen, this is not a financial crisis. This is a public health crisis. Why do you keep putting fiscal stimulus in pretending this is an economic crisis? Why don't you put let me just be clear, Marshall. I think the fiscal stimulus, the bailouts, I think those are really important. I think they have to be done. I would like to see them done in a targeted way. I think those are really important, and I'm very grateful to the federal government for doing it. I have to say that. But there hasn't been the same amount of money going for public health. We're probably going to need hundreds of billions of dollars to set up this complete response. But that response is going to have to be in place for the next time COVID comes back. We now know life has changed forever because we know this is possible, right? And travel after 9/11 changed forever because we knew that was possible. Now that we know this is possible, life has to change forever. Public health is going to become a part of everyone's life, probably every day for quite a while. But then you're going to have these supercharged systems ready to take on anything at a moment's notice. And you're going to have to be able to recruit, contact tracers, whoever, like a volunteer fire brigade. You're going to have that system ready at all times because we now know that a virus that's just made out of RNA, right? Just a virus can bring down the entire global economy.
So, Dr. Jim, would like to call on history and also your anthropology background. So you've dealt with, these are the multifactorial strategies of contact tracing, testing, social distancing have to work in tandem. And in the past, you've dealt with drug-resistant tuberculosis, you've dealt with Ebola, you've dealt with AIDS. And often the solution is simple, but the biggest obstacles, as we've seen in history, is the social, political, the human factors, right, that are resistant to the adoption and the scaling of those solutions. But you've done this before. So looking at the past, how have you persuaded, because you've worked with governments in Africa, you've worked with governments in Latin America, how have you persuaded them to partner in these joint efforts of making public health the number one aspect?
Well, Sanyan, when you say that, it reminds me of what Marshall has literally pounded into my head for the last, 12 years, Marshall. Marshall says the most important things in life, the most important things in leadership are simple but not easy. Simple, not easy. Simple, not easy. And so I think that's the big lesson here. You're right. It's simple, but it's not easy. And the not easy part scares people away. Right. So in Africa, the reason that we started in Massachusetts is based on our experience. Right. We believe in the threat of a good example. Partners in Health believes in the threat of a good example. And so for HIV, what happened was we started just showing before and after pictures of our patients in Haiti who looked like they were literally dead. You guys have seen the pictures. They're in the movie of people who look like they're dead, and then all of a sudden, after 2-3 months of antiretroviral therapy, they look wonderful. And we called it the Lazarus effect of HIV treatment. And so that example, just those before and after pictures, had a huge impact in Africa. And let me just tell you a quick story that illustrates this. So we were at the 2000 and when was it? 2006, I think, HIV/AIDS meetings, and we went to a booth that was showing the treatment of patients in Kenya, right? And we went there, and they had a before and after picture from Haiti. It was the one that I had put everywhere, and the patient's name was Joseph June from Haiti. And so we looked at that picture and we said, "Oh my God, that's Joseph June from Haiti." And they said, "No. This is a patient in Kenya." They told us where he was from, and they had this whole story. And they believed it. They really believed that was a patient from Kenya. And so we said, "Well, we actually brought Joseph June to the meeting." So we took Joseph June and took him to the poster, and they said, "Look, here's Joseph June." And so the Kenyans, rather than getting angry, tears came down their face. They hugged him. And what I learned was that those before and after pictures became a powerful symbol, not just in Haiti, but everywhere in the world, that they saw someone who looked like them going from skin and bones to looking great, right? And so it's one thing to talk about what needs to be done. It's another thing to say, "Oh, and by the way, we're doing it here," right? And so once we got started in Massachusetts, other states called. I am a great admirer of so many of the governors. J.B. Pritzker, Governor Pritzker in Illinois, Governor Mike DeWine in Ohio, and both of them called me when they heard about what we were doing in Massachusetts. And again, I said, this is going to be really complicated to get done inside your system. The idea is very simple: test, trace, isolate, quarantine. It's very simple, but it's going to be really complicated. But we will be there to help you. And so, we're starting in Illinois, we're starting in Ohio, we're probably going to start, in a city, Newark, New Jersey, and then the list will go on. And, this is why I'm so grateful to Governor Charlie Baker and Secretary of Health Mary Lou Sudders. They took a big risk in taking this on. We didn't know, and I remember telling them before the press release came out, I said, you guys have to be ready. There may be ridicule and criticism that comes at us once we make this announcement. So they took a big risk. It doesn't look like one now, but that's what leadership's all about. I think both of them, and I was talking to both of them in that first conversation, I think both of them just felt so badly for their own people. They felt so badly for their own people. And, Governor Baker, when the first, we helped them get a huge shipment of N95 masks in from China. And when that plane landed, Governor Baker was there. It was a New England Patriots plane, and many thanks to the Kraft family for doing that. As he was talking about that plane that was behind him that was coming in with masks, he started crying. He wept, and he didn't weep openly, but you could tell he caught his voice. So here is a man crying because he didn't have masks to protect his own health workers, and so happy that this plane had landed with a shipment of masks. When you can cry about masks, that means you care for your people. And that's what we need to see. That's the leadership we need. If you care about your people, we are ready to help go on offense and really stop the transmission of this virus. But you got to be ready for difficulty, and you can't quit once it gets tough.
And love.
Dr. Jim.
Courage and love.
Love,
Dr. Jim,
absolutely. He felt so badly about his health workers, and he during the process of getting them here, it would be phone call after phone call. Come on, we've got, and there were so many difficulties. I have very close friends and colleagues who are in Hong Kong and China, and because of my work at the bank, we have some connection still to the Chinese government. There were so many things that we needed to do to get it done, but again, the bottom line was that the Chinese government understood how important this was and it went out of its way to make sure that the shipment got to Massachusetts.
You know, Dr. Jim, I want to talk about the economics of this. To me, there's a false argument. And the false argument is either you tackle the public health issue of this or you tackle the economic issue. And that basically, if you tackle the public health issue, we will have an economic depression of unprecedented magnitude. Here's why I love what you're doing, not just from a public health perspective, but from an economic perspective. And please correct me if you think I'm wrong. Let me give you a simple example, California. Now, California, we're talking about social distancing for 9 months. This is an economic disaster. They're saying, well, restaurants can operate at 40% of capacity. No, they can't. If your maximum is 40% of capacity, maximum, you're going to go bankrupt. The shopping mall, bankrupt. The restaurant, bankrupt. You can't let this drag on and on and on. This is going to be an economic bloodbath if we don't fix it. Now, to me, the cost of what you're talking about is not inexpensive. We have to tell the truth. We could be talking tens, hundreds of millions of dollars. This economic bloodbath is going to go way beyond tens or hundreds of millions of dollars. If we do not fix this, I think the cost to the economics is going to be trillions of dollars, but that doesn't even touch the human dimension. The human costs of all those small businesses going bankrupt. You can't just do social distancing. You can't put a Band-Aid on this. It's not going to go away. It's not going to go away by itself. Flattening the curve is nice, but flattening the curve is not eliminating the curve. When you flatten the curve, it's just going to come back, as you said, and the economic cost of this is going to be hideous. If you don't mind, number one, does what I say make sense to you? And then number two, can you talk about the economic argument in favor of what you're talking about, which I think is just as almost as important as the political public health argument?
Marshall, you coached me all through this, but I went from being, a university president, a public health person, to being a finance person, right? So this is why I'm so what's the right word? I'm so on a mission about this because it doesn't make sense. Right? We're talking about in terms of fiscal policy and monetary policy, we're talking about unprecedented efforts. $2 trillion fiscal stimulus, monetary policy, where with bond buying and interest rate lowering, the likes of which we've never seen before. I used to talk about that all the time, and now we're seeing these measures. I'm glad they're taking them. They're talking about bazookas. They're talking about the nuclear option. So if you're going to use bazookas and the nuclear option on fiscal and monetary policy, why are we using squirt guns in public health policy? The public health folks still feel like there will never be enough money to do the full Monty, as we say. You've got to do the whole thing, and the cost of it is going to be whatever it costs. Whatever it costs, we've got to stop this. And people ask me all the time, so when will this stop? And I think the evidence is pretty clear. When you get to the point where you're actually stopping transmission of the virus, when your people are socially distancing to stop inter-household transmission, when we have testing, tracing, right, isolation, and quarantine, so that you're stopping intra-household and other and health worker transmission among store workers. When you're going after every single site of transmission and you're going after them and stopping it, when you have that system in place for your population, then probably 2 months after that, you can really think about opening things up like they did in Wuhan. Now, after you open things up, things are not going to go back to normal for a while. I mean, I think that there are social distancing now. It's going to be I think after the vaccine before we really change practices. I saw an article the other day about will the handshake be gone forever? I don't know the answer, but boy, until we get a vaccine, I think life will be different. But to get back and running economically, that's just simply what you have to have in place. And right now, it's just wishful thinking. I mean, it really kills me to see this, because there are optimistic models out there that says the U.S. is going to follow Wuhan, and it just won't. And already those optimistic models are proving to be misguided. They're proving to be incorrect, because the most optimistic models said the rate's going to really drop at the end of April. Well, we're close to the end of April. It's not dropping. And what we hear from all the large states, Governor Baker, Governor Cuomo, they're saying, well, it's flattening, but it's not going down. Gosh, what do we do now? It's flattening, but it's not going down. And so there's this idea out there that as long as it goes down for 14 days in a row, then you can open up the economy. Again, there's really no evidence for that. Wuhan waited until it had literally zero transmission. They had only 3 cases in 14 days and 0 new transmissions in Wuhan. And then after 14 days after that, then they opened up the city. And even then, it's not really completely back to normal. So other parts of China are back to normal. Other parts of China are, the roads are full and things seem to be moving. Wuhan, not yet. And so if you have the system in place, as China does, China has the system in place, ready to go. Any province, anywhere in the country, they go after it. Korea has it. New Zealand has it. Australia has it. When you have that system in place, then you can start letting things go back to normal. And it seems to me that being able to say, now that we're really tracking every single possible transmission, we think it's going to go down in 2 months. That seems priceless to me. But it's not. We're not having that conversation yet.
So, Dr. Jim, so much.
So, Sun Yin, can you give Dr. Jim maybe a couple of final reflections? Then I'll have you comment, Dr. Jim, and we'll wrap up. So, Sun Yin.
Well, one is so much of leadership matters. Leadership matters. I mean, that's why we do. Marshall and I, we do what we do. But when I think about this, so much of what you talk about with creating that system seems to be in the hands. The decision seems to be in the hands of government leaders. Question for you is, give our viewers a sense of agency. What can our viewers do to help be supportive and help be part of the soldiers in winning this war on COVID, Dr. Jim?
Well, directly, they could become contact tracers. We have another whole group of people we call resource managers. And what they do is they find out what people need. What do they need in order to be able to keep themselves and their families safe? That's a great job. We have others who have more experience in health and in public health. They're the case investigators, where they look more closely at the specific medical problems, connecting them to medical care. There's a whole group of people who are doing that. And so if you can get directly involved, that's great. Remind everybody, and then this is a message from Massachusetts, answer the call, everyone. When the contact tracers call you, answer the call. We're trying to get up to a point where everyone is answering the calls, because we want them to know that we're there to help. We're there to help them be safe, for them to get the right care, and for them to keep their families safe. So that's one part of it. But the other, I think, really important part is that the citizens have to demand that we put this system in place. If there is a proven approach, and the different people seem to have different kinds of reactions to evidence coming from specific places. Well, look, as far as I can tell, and the message from the World Health Organization has been exactly the same for the last 2 months. You cannot get rid of this virus. You cannot win the war against this virus without doing the full response. There's plenty of evidence out there that it works. Look at Australia and New Zealand, if those are the countries you want to look at. Demand that your leaders put this system in place. Just demand it. And if we hear that from more and more people, you've got to put these systems in place, and you got to put all the things that you need to make it work. It includes money, it includes testing, it includes a temporary workforce that my friend Tom Frieden, former director of the CDC, has talked about 300,000 people. I think it could be more than that. And they may not be out on the job for very long. It might be months or maybe a year, but we're going to need them for now. Demand that the system be put in place. It's not, I haven't made it up, right? This is not my idea. This is just simply what we know from looking at this virus all over the world.
Thank you.
Dr. Jim, thank you. Oh, go ahead, Sanyan.
So it's basically, if people want to volunteer to be a contact tracer, they can, where would they go? It will be the Partners in Health website. And then also invest in public health.
Right. So Sanyan, we're actually paying people. And so it's turning out that it's actually a great jobs program for people who need work. And, we're paying anywhere from $27 to $35 an hour. And we think this is great because we think the government expenditures should be aligned with stopping the epidemic, stopping the virus. And so this is, I think, one of the few examples in the United States where there's money that's going to people so that they can have a livelihood, they can buy groceries, they can do whatever else that they need to do. And at the same time, they're fighting the virus. We would love to see these programs sprout up everywhere. I mean, everyone talks about volunteer programs, but what happens is, if it's a volunteer program and you set up shifts, what if half the people don't show up? Because it's hard work. It's not. It's you got to follow a script. You have to be empathic. You have to be able to talk to people. This is not an easy job, and so I don't think that you would want just volunteers doing this work. If it's important to you, you should pay people for it. So for Massachusetts, and I strongly urge other governors to do the same. Find the money to pay people so that they're serious.
I just love what you said. I mean, why are we talking about look, these infrastructure programs for bridges and stuff are all important. Nobody's knocking that. On the other hand, compared to this, they're trivial. This is so much more important, so much more real, and is doing so much more damage to human beings and to the economy. Finally, Dr. Jim, if you had one last thought you'd like to share with us before we depart, what would be a final thought from you?
Well, I think that, the people who watch you guys, and I know you both have huge audiences, they're interested in leadership. This pandemic, this crisis is going to require great leadership from everybody. And in no matter what it is that you do, no matter how many people you lead, even if you don't lead anyone, the leadership principle here is pretty clear. You've got to think about what's the right thing to do for the people. What's the right thing to do, not just for me, not just even for my employees, but what's the right thing to do for everyone? And I think the answer has come at us loud and clear from all of the countries that have had success in doing this, and even all of the countries who've had less success. The answer is loud and clear. And the other part of leadership is fearlessness in the face of something that seems simple, but it's really, really difficult. Our country in the United States, but the world itself is going to define itself and define its mettle based on how courageously and how determined we are to actually tackle this mountain of cases that we have. Every single person has to say, we're not going to stop because it's difficult. I always, during the HIV days, I used to use this analogy. I used to say that, when President Kennedy said, we're going to go to the moon, I don't think the folks at NASA said, it's too far, it's too hard, it's too complicated. They said, well, maybe this wasn't the top priority for NASA, but what a challenge. Let's get about doing it. That's the spirit we have to have right now. The challenge is in front of us. We cannot walk away from it because it's hard or it's difficult or it's complicated. This is the nature of the task. Let's get at it.
Dr. Jim, in closing, I'm so proud to know you. I just think you're one of the best human beings I've ever met in my life. You're just a good person. You didn't have to step up to this. There's a lot of other things you could be doing if you were self-interested, which you're not doing right now. Sanyan, one of the great people that is one of our group, is Harry Kramer. He says, there's two questions to ask. Did I do what I thought was right? Did I do my best? And, you know, I really think you're a person, you're doing what's right and you're doing your best. So anything that we can do to support you is just a minor contribution to what I consider to be a huge and a very, very important effort. So just a couple of points to our listeners first. Look, we all need support. And Dr. Jim is not doing this for recognition or support, but if you could just write in some positive comments that I think for him and for the efforts he's making, that we could just summarize and share with him, because, you know, day after day, he's putting in hour after hour. He's sacrificing his own money, he's sacrificing his time, he's sacrificing his life to do this, to help other people. So just some positive comments or support, that would be very, very good. And the second thing is, finally, just thanks to everyone for listening. I hope this has been inspirational and helpful for you. I hope that we're really out there. Let's win this war. Let's don't placate, pacify. Let's win the war. The things that we've done that are great, we didn't try to come in second place, we tried to win. Well, this is a far more important battle, one of the most important battles in my lifetime. So I think we need to win the war. I love what Dr. Jim is doing. Dr. Jim, thank you so much for joining us. So honored to know you. And again, any help that any of us can give to you, we would be honored to make some small contribution. So thank you very much. Thank you.
Well, Marshall, if I can just say one thing. So we're doing this through Partners in Health. And, you know, the protocols and all those things are now on the Partners in Health website. But if anyone has some extra money sitting around and they want to donate to some group, you know, we've been doing this. Of course, I'm a supporter of Partners in Health and I'm on the board. But we've been doing this, and now the demands for going to other places is increasing. So it's a great organization. If you want to donate money, Partners in Health is a good place to do it. But also just keep up with what's going on the website. I think you'll be very encouraged to see the states and the cities that are coming on board. This is it's encouraging to me, and it's all there on the website.
Thank you so much. Thank you, Dr. Jim. Thank you so much.
Thanks, everybody. Thank you.
Thank you.